by blocking this structural protein in biofilms, what it does is dismantles these biofilms. Yeah, that's, I guess, a new approach to targeting bacterial infections to avoid developing resistance.
Today, I'm chatting with Professor Begoña Heras and Dr. Jason Paxman, who are researchers based at Trobe University in Australia. Their individual and joint research is internationally recognised, and together with their collaborator, Professor Mark Schembri, they formed BioBreak Therapeutics. The company is a biotechnology spin-out developing anti-biofilm therapeutics to treat chronic urinary tract infections. I'm excited to hear more about your work, and there's been a lot of interest from our community. So thank you so much for joining me to share it.
Thank you.
I think it'd be great to start with some information about your background so you can tell us how you came to be working in the UTI space.
I can start. I'm a structural biologist, so my background is studying protein structures at atomic level and at a high resolution to understand how they work. And in particular, for a long time, I've been focusing on bacterial proteins, and in particular, bacterial proteins that form biofilms, including proteins from uropathogens, and that's how I started working in this space. So trying basically to understand how proteins mediate infections and biofilms.
Yeah, and I've basically been running in parallels to Begoña. So yeah, I'm a structural biologist as well, and yeah, I'm just interested in, I guess, how bacterial proteins cause like infections and disease, like Begoña. And, you know, we work on quite a few different types of proteins and understand their roles in infection. And then with understanding their roles in causing infection and disease, what we're interested in doing is actually using that information to develop antimicrobials that basically target these proteins. And so, yeah, we looking at various different proteins from different bacteria, we come across antigen 43. And essentially because this protein has such a profound effect on biofilms, we started basically working on it.
So you mentioned antigen 43, and this seems quite complicated, but our patient community is very well educated around the topic of biofilms, and it really fits with the patient experience of how they have continuous symptoms or their symptoms keep coming back despite treatment. And I think that's why this topic will be of such interest to the community. And in your paper, you mentioned that the antigen 43 works like molecular Velcro to help bacteria form biofilms. Can you walk us through how that mechanism works?
Yeah. So basically, this protein is a bacterial surface protein. So we have, in this case, is E. coli. So it decorates the surface of E. coli cells, and it's translocated, stays on the surface. And what happens is when bacteria come in close proximity, these little proteins act as almost as a Velcro, where they bring bacteria together, forming bacterial clumps. So each protein with the neighboring protein forms like little handshakes, little interactions, and all this brings basically bacteria forming clumps and biofilms. So this is what we looked at really high resolution in detail to understand how this little protein was mediating, had this profound effect in forming biofilms from uropathogenic E. coli, for example. And that leads to the technology that we are discussing today.
When you say high resolution, does that mean you have imagery of this mechanism in progress?
Yep. We've got a crystal structure. So we've actually got a crystal structure of this Velcro. So for the new generation people out there, Velcro is basically when you've got two things that are sticking together. It's a bit of an old thing, and essentially, yeah, we have the crystal structure of the antigen 43, or my hands of the bacteria, and this is the antigen. We have a crystal structure of the bacteria, the proteins sticking together, which mediates the bacterial sticking together in the biofilms. But also with our therapy, our antibody therapy, we actually have a crystal structure of our antibody bound to the antigen 43. So that was integral for our patent application for working at this antibody bonds to, because a lot of therapies these days, they don't know exactly how that therapy works at a molecular level, but we have that information, so which is important for developing further.
Yeah. I saw also in the paper, the therapy that you mentioned, you said that it disarms rather than kills bacteria. What does that mean, and how does that compare to the way that antibiotics work?
Yeah. conventional antibiotics work by blocking essential pathways in bacteria, so for bacteria to survive. So that's why they kill bacteria, and that's the mechanism of action. In our case, it's a bit different. So our therapy or our technology doesn't kill bacteria. It doesn't affect an essential machinery in bacterial survival. It just blocks this. It blocks a key protein in these big biofilm structures. So by blocking this structural protein in biofilms, what it does is dismantles these biofilms, but it doesn't affect the viability of bacteria. We rely on the immune system or antibiotics, depending on the approach
Clearance
that we use for bacterial clearance. So the technology itself does not kill bacteria. So that's why we say it disarms bacteria, it makes bacteria susceptible, but doesn't affect the viability itself. That's I guess a new approach to targeting bacterial infections to avoid developing resistance readily.
Right. And this type of therapy, how do you imagine that it would be administered to a patient with chronic UTI?
Yeah, so we've been looking at different types of administration. So intravenous would be one option. Also exploring the subcutaneous administration as well. So don't want to be jumping across extra questions, but yeah, we were thinking about administering. I mean, it's still early days, so we just want to make that quite clear. I mean, we're still in lead optimization. But we're looking at a dose, maybe a few doses in the first week in the first week, and then maybe one dose maybe for the next following couple of weeks. But disclaimer, it's very early. And we're yet to optimize in animal models and things like that. So
if it's delivered like via IV or subcutaneous, how do you know that it will actually reach the bladder to do what it needs to do?
We have seen in animal models, because antibodies are cleared by the kidneys into the urinary tract, basically. So we have seen that our top antibodies readily reach the urinary tract in animal models. So we do know that, and the concentrations that would be required for inhibiting biofilms. So that's a well understood process. What we don't know yet is eventually what is the dose that we will be using, and this is what we are working on. The dose, the number of, I guess, doses that we will need for clearing the infections and so forth, how it could be administered better with the IV or subcutaneously, all that is this is the money that we have now to develop, to basically get answers for all these key questions.
Once it is delivered, how long do you think it might take for someone to experience improvement?
Yeah, well, in terms of the clearance, like Begoña was saying, that when the antibody is cleared in the bladder, literally it gets there even with an intravenous injection, like it's literally there within a few hours. So we would expect symptoms, or at least some sort of symptoms to be there quite within the first 1 or 2 days, really. By the time it's broken up the biofilm and the bacteria have been cleared out, and then the symptoms then relieve. So pretty immediate, yeah.
Do you think the symptoms might worsen initially because of the biofilm disruption?
I don't think so.
Probably not.
I think that in the bladder, with the biofilm disruption, what you'll find is that the urinary clearance, so the normal flushing of the urine, will flush a lot of that bacteria out to begin with. Yeah. So I think if it was a bloodstream infection and you're disrupting biofilms and you've got clumps of bacteria floating around, that would be a different case altogether. But I think in the bladder, the fact that it'll get flushed out, I think that would be, yeah.
That's the question that comes up quite a lot when we talk about biofilm disruption in the patient community. Is it a sign that it's working if your symptoms get worse when you take something? And this question has not really been answered. So I thought I'd add that one in, because it is interesting. And logically, it might make sense if you disrupt a biofilm and the bacteria are released into the urine, maybe your body's immune response is exacerbated for that. But I guess you'll find out when you do the trials.
Absolutely. Yeah, that's something that needs to be addressed.
Yeah. So do you think this treatment could be used during an active UTI, or is it more for a prophylactic or preventative approach?
We think it's more for an existing infection. This is more designed for recurrent infection or chronic infections. So that's where we think the technology would be best used. That doesn't stop us or the clinician from using it as a prophylactic approach for preventing, say, when you are, I don't know, with what do you call the
or for often one of the treatments for long-term urinary tract infections is actually a prophylactic treatment of antibiotics, sort of low concentrations of antibiotics over a long period of time. They've found it doesn't make sense, but it does work.
But this case would be much better.
Yeah, ours would work.
Low concentrations of antibiotics, the only thing they can do is enhance the antibiotic resistance development, whereas this one shouldn't lead to AMR, antimicrobial resistance. So, yeah, it could.
Prophylactically, ours would work really well. Essentially because, like Begoña mentioned before, it's not actually directly killing bacteria. So we do envisage that we will get some resistance over time, but the resistance will be much, much lower than what you have against conventional antibiotics. So actually, our therapy would make sense for long-term prophylactic treatments. But I guess what we're going to be testing for in animal models and our initial clinical experiments will be sort of recurrent infections. So I don't think our therapy, the fact that when someone presents with a urinary tract infection, an acute urinary tract infection, it's their first infection. I mean, look, antibiotic, it's so easy. It's a tablet, you can take it, a short course of antibiotics. And for, a lot of cases that'll be cleared up. Where our therapy will step in is when, someone comes back with a recurrent or a chronic infection, and that's where we think our space is. But prophylactically, it could work too.
It could work. Yeah. But this is not what we are looking at as a
not initially.
Okay, but it is interesting because I think I've seen some research that shows that biofilms start to form quite quickly in the bladder after an initial infection. So even if someone takes a few days to get to the doctor to get antibiotics, it already could be an issue. And I think that's probably why we see such high recurrence rates. So it would be interesting to see if this therapeutic can become part of a first-line treatment for acute UTI to prevent those future episodes. Do you think there might be side effects from this therapeutic, and how might those compare to antibiotics?
Well, typically antibodies are quite specific on the target that they block. So that means that the side effects, the risk of side effects is much lower than in any other drug. So from that aspect, we would think that the side effects would be lower than regular antibiotics. Also, we are not targeting this technology wouldn't target our microbiota as such. So that would be prevented, meaning we wouldn't have these secondary infections happening as well. So in terms of side effects, like any other antibody technology that is currently being used for conditions, the side effects would be lower than any smaller molecule or small drugs that could target different pathways.
And remember, we're just using antibodies, which are essentially in our bodies already. So it's not something, completely foreign to the human body, not like an antibiotic, which is a chemical. That's the good thing too.
Yeah.
With we've talked about, you mentioned it too, that antibiotics can tend to be less effective over time. How do you think that this therapeutic might help with that cycle? And do you think that using it in conjunction with antibiotics might actually be more effective?
Answer this one. Yeah. So when you have a biofilm infection, and a lot of your people would know this, that and you treat it with an antibiotic, and obviously that antibiotic doesn't have the access that it needs when there's a bacterial protective biofilm. So the antibiotic can't get into that biofilm and basically kill all the bacteria. And so what you end up with is and we see this in the lab as well, when we treat a biofilm related infection with antibiotics, we don't get complete clearance of bacteria. And essentially those bacteria have been exposed to that antibiotic that you've been using. And so because they've been exposed to that antibiotic, they get resistant to that antibiotic, and then those bacteria will grow up again. And so then when you give an antibiotic again, and if it's the same antibiotic, or even if it's a related antibiotic, those bacteria will be resistant. So our idea is to basically with our therapy, in breaking up the biofilms, we're removing this protective coating that the bacteria have, and we're hoping to basically clear a much larger proportion of the bacteria from the infection, and so reduce the likelihood of bacteria surviving and staying on and basically growing up and having recurrent infections. So yeah, and we can talk about the therapy.
Yeah, and I guess in the lab we have shown synergy between our technology and antibiotics that we have shown in vitro, let's say. That
no, that's right. Yeah, so we do think that, you know, one of the effective ways of using our therapy would be in conjunction with an antibiotic, so a course of antibiotics.
Basically could rescue antibiotics that have become obsolete for the treatment of this condition. So this is part of the progression of the project that we envisage investigating as well, like how good it rescues existing antibiotics.
Which is exciting too, because there are so few new antibiotics in the pipeline, and especially for UTI, and patients in our community are often running out of options. And the one question that they always ask when we talk about a new therapeutic is, will it work for chronic infection? And most of the therapeutics coming through the pipeline are not really targeting chronic infection. And that is what our community is really interested in, because a lot of people have been suffering for decades. And something like this could really provide options for them where they haven't had any. So there will be a lot of excitement. And it's one of the reasons I wanted to talk to you both, because I know that you recently were successful with a grant application, and I would love to hear more about that.
Yeah, I can start a little bit. So this has been many years of research. Initially, all the fundamental research was funded by government grants, where we were successful, and we were basically using this money to understand the mode and how these bacteria were generating or creating these really resilient structures, the biofilms. And this, we did it from the fundamental perspective, understanding how it works, as Jason said before. And then we used initial funding to get I guess, to develop the technology, initial technology, to see, well, can we, now we know how they work, can we block these processes? And we did. And the recent funding, which is the one that Jason mentioned as well, is this, we've received now the funding to further take that technology throughout the translational pathway. And this funding is now led to us setting up a company because sometimes in science it's really hard to get that intermediate, that funding for preclinical lead development and preclinical studies, clinical development. So that's where we are at now. We've got funding to do that, and for this, engaging with the community has been essential. And Jason has been leading all that. He's the one that
the community's been fantastic. Like the support. The support from Live UTI Free, and also our local Chronic UTI Australia support from people has been fantastic. We were, when you put the call out, Melissa, my inbox was just inundated with testimonies and support for our therapy, which was fantastic. You know, I think in the end we had about 350 testimonials.
It's amazing.
It was fantastic, and just so that, you know, people are aware that their names are anonymous. So we've kept all these testimonials confidential. I've actually marked over the names so that no one can see the names, and we've kept it confidential. And all we used for our grant application, because what we wanted to show was, and even us, like looking at these testimonials, and even for us, it was inspiring to see these testimonials and see what people are going through. I had no idea that people had these infections for 40 plus years. And we were in a way sad and for a lot of people, and inspired, you know, to actually do what we're doing. But what we wanted in the grant application is we wanted sort of impact statements, like one-liners. So that's essentially what we look through the testimonials, and we look for sort of one-line sort of impact statements that people had. And that was what we put into the grant. So just to be 100%, because people have asked, there's been no names, and all of the testimonials, the testimonials themselves are confidential, and, you know, never see the light of day. It was phenomenal, the support that we got, and it was inspiring. you know, and I I remember having them all together and I read through them all and I was like, wow.
Yeah. It really shows how this is an unmet need, how much people are suffering from an infection that unless you are involved, people might think, oh, just take an antibiotic and it's over. And also, like you said, helping us showcase that to the funding bodies, but also designing like inspiring and also helping us design what we want to do, how we want to do it best to better find I guess a cure that better suits the community. So it's all inclusive. So it's been great.
Yeah, it's really synergistic, isn't it? Yeah, it's helped us too because we've been campaigning in Australia for increased awareness around the condition as well. Because you know, I guess because the death rate is reasonably low, like the direct death rate from chronic UTIs is quite low. Governments around the world, including our government, don't take it seriously.
We see that too.
And so so we've been promoting awareness around it, and having those testimonials has helped us sort of frame, you know, what's actually going on in the community. So yeah, thank you everybody.
Thank you.
And I hope
us focused. I say this is really important. You know, sometimes when you are used to doing something, we need to make sure that we don't lose track and we. You know.
And I tried to write back to most of you. Sorry, I ran to everybody. It was just a lot of emails.
Yeah, it was an amazing response. And I'm not sure if people remember submitting a testimonial for this, but it was a year or so ago, I think, that we asked, and so many people responded. And that's another reason I wanted to do this interview, so that people who did submit a testimonial can now see that it was successful and the grant has happened and the research will go ahead. And that's really exciting to actually see something come right through to that successful outcome. And that's the next question that people will ask. Now that you have the grant funding, when do you think that you might go to human trials?
Human
trial. Well, we right now we are in the early preclinical, basically. So lead development and full preclinical testing, and then we think within 2 years, 1 to 2 years, start the clinical phase 1. What we envisage is within 5 years having the technology out, but that's a bit of an optimistic, but that's what we envisage to do.
And what kind of patients do you think you might want in that trial? What criteria will they need to meet?
Yeah, so ideally, what we're looking at is basically we're looking for a therapy for chronic and recurrent infections, and so we're going to be looking for patients that have had a recurrent or a chronic urinary tract infection. Particularly looking at those which have got infections from multi-drug resistant bacteria populations that have multi-antibiotic resistance, and they'll be our first the patients that we're going to be looking at initially. Yeah, I mean that's where the real area needs to be addressed. You know, those patients where there's no treatment available for them, and that's our space to look at them.
Yeah, we are working together with clinicians specialized in antimicrobial, antimicrobial development and microbial infections, and including UTIs. So they are helping us. They really are going to be the ones helping us develop all these, setting up the clinical trials and the strategies, because that's not our area of expertise. But we have managed to get a team of experts, including microbiologists, clinicians, and experts in antibody technology. So hopefully together we can see an outcome within this time frame that we mentioned.
Yeah, we're just scientists.
Yeah. Do you have a patient advisory group in place too to help throughout this process?
We don't actually.
Yeah, I mean, in terms of the patient advisory group, I mean, your organisation and Chronic UTI Australia are the closest that we have to be reaching out to patients. I mean, essentially, we're just laboratory scientists that come across something which looked effective, and we've thought, let's take this further. I mean, we're not going to be making any profit from it, but we're just literally just thought, well, it's a good translational opportunity. Hopefully it'll make a difference. And so that's basically where we're at. So we're stuck. Well, we're not. Well, it's not. I shouldn't say stuck, but now we're left with getting this thing into moving this thing into the clinic and basically running a company. and neither of us have got. I mean, we're lecturers slash researchers at a university, So, but we're doing our best.
Yeah.
Yeah.
No, and it's true that in our institute, for example, and in Australia in general, now to bring any to develop any research that is medically important or medical research, patient groups, advisory groups are essential. So thanks to that, now, for example, our institution is basically developing a patient advisory group portfolio for different conditions that we are working on here.
Yeah.
And we could take that avenue to be able to include some patients probably, like officially being paid and all that, so that we can have a group of people that can help us, and we can hopefully help us.
Yeah,
well. So
we'd be interested if any of the community wants to be involved. We would be
I
definitely
think
interested if they
there will
contacted
be
us.
a lot of
Yeah.
enthusiasm. So if there is a way for people to get involved at some point, we can share, and Chronic UTI Australia also will be able to invite
That
their
would be
community. There are plenty of patients that want to help advise on these trials, because it's so important to make sure, like you said at the beginning of this interview, to make sure the trial is designed in a way that suits patients, but also the measures, the outcome measures for the trial. What are you actually measuring to make sure that patient quality of life has improved, not just biological markers and things like that. So really, really important. And our community often gets involved in that way to help develop trials to make sure that they suit patients. But that is one of the questions that I had. What measures are you looking at to evaluate the success of the therapeutic?
Yeah. So I guess clearance of infection, clearance of biofilms, those are the main, especially in the lab that or in the clinic, that we will be measuring relief of symptoms that disappear, that is no recurrence of the infection, because that's also, I guess, lack of resistance as well. We need to measure that. So it's, I guess, multifactorial. It's multiple things that we are looking at measuring in terms of to see that the technology basically is working.
We could follow up with patients like 6 months later or a year later to see if there's been a recurrent infection. That would.
So that's what we are considering. Well, we do some of that in the lab now, but with patients, it's obviously different. It expands.
Yeah, and this therapeutic could really help a group of patients which is often left out of studies for UTI, which are those people who have continuous symptoms of UTI.
Yeah.
And so thinking about how to measure their outcomes, whether it's just a reduction of symptoms, that would be amazing. But they're often just not included at all because it's complicated, and most of the outcome measures are looking at a reduction of frequency of UTI. But for patients who have symptoms all the time, you can't just measure that. But I would be interested to see if your research can include that group of patients, because they're really the ones with the chronic infections to the point where they have those continuous symptoms and they really need this type of therapeutic. And I think that you would also hear that feedback if you put together a patient advisory group to try to include that subgroup of people.
Yeah. I'm taking notes at the same time. So
we can always chat about it later too after the interview, and we can help bring patients to the conversation, as I said.
That would be fantastic.
That would be good.
That would be fantastic.
I'll mention one more thing. For those patients that are actually got antibiotic resistant infections, and where antibiotics may not be, they may not be able to resort to antibiotics anymore because they've essentially exhausted the list of antibiotics. Envisaged our therapy could also be used as a monotherapy as well. So the fact that you've got these resident bacteria and these biofilms that are protected, our therapy, by breaking up the biofilms, should be able to, we hope it should be able to clear infections from a lot of people in the absence of any other antimicrobials, simply by clearing the biofilms once they've been broken up. And then also remember that you've got an immune system in your bladder, and so which can control infections as well. So hopefully, with clearance from urine flushing and the immune system, that should, it could potentially, our therapy could be used. We'll be looking at it to be used as a monotherapy as well. So there's hope for people.
And do you think that then might preserve antibiotics for acute UTI because they're just not needed as much in the recurrent and chronic population?
They should, right? If we won't use them as much. So in that way, resistance will take longer to develop. also, if we make the biofilm bacteria within the biofilms more accessible to antibiotics, we don't need these long courses of antibiotics that also lead to antimicrobial resistance. So we think it will could rescue antibiotics, preserve the newer antibiotics because they are less used, and also because we use less of them. We don't need these long courses of antibiotics to biofilms that often are not even effective. So by touching into all this, we think our expectation is that yes, the antibiotics will last longer, and we will be able to rescue antibiotics that have become useless in that context.
Yeah, it's really encouraging because there are a lot of people in the community who just can't take antibiotics anymore because it's had side effects or their microbiome has been damaged and they just can't. The side effects are too much now for them to use them, or they're just not working and they just don't really have any options that they can take. So they live with the daily symptoms of UTI. So having an option like this in the pipeline, and if 5 years is really when it might become available, that still feels like a long time, but it's something, and it gives people
on the horizon, isn't it?
Yeah, it feels attainable. It's not 20 years from now, and it might help a lot of people in this community who are still suffering from symptoms. I know that the community will want to keep up to date with your work and to find out when the trials are running so they can participate if they're in Australia. I take it the trials will be Australia only?
No. We're yet to work that out.
Okay.
We haven't yet picked a clinic where we would do the trials. So that is yet to be seen.
Yes.
So
the clinical trials in Australia are quite good. So initially we probably, but it's decided.
We haven't decided yet. So don't just because you're not in Australia doesn't mean you can't be involved.
Yeah.
Well, we have a lot of collaborators in the UK and the US too. So if you're looking for sites there, we might be able to put you in touch with some researchers. And I know the patient community would be excited to hear if it was a multinational trial.
Okay. Yeah, that'd be that's good to hear. That's good to hear. Yeah. Yeah.
So how can we keep up to date with what's happening? And how is there some way the community can sign up directly, or can they find out through us and you'll keep us up to date?
Yeah. So as we mentioned, so we've now got the funding to then form a company. So we're forming a company called BioBreak Therapeutics, and you'll be able to find us online. So at hbsbiobreak.com will be our website, and there we'll be posting news and updates about how we're progressing with developing our technology and any other updates in terms of clinical trials and where you can subscribe to those. So,
amazing. We can put the link to that in the video description. And when you reach a milestone, if the trial is being announced, I'd love to chat to you again about what the trial looks like and how people can get involved.
Yeah, thank you.
Fantastic. Yeah,
your help would be amazing, actually.
Thanks so much for joining me again. And I'm really excited to see what comes of your work.
Thank you very much. Thank you.
And thanks to the community. Really appreciate it. Really appreciate the support, don't we? Yeah.
Thanks so much for watching. I hope you found this expert video helpful. If you'd like to learn more about this or related topics, be sure to check out our other videos or head over to liveutifree.com for related articles. We'll drop some links in the video description. If you like what we're doing on this channel, you can support our work by hitting subscribe here on YouTube, and don't forget to tick the bell so you'll be notified of our future videos. Thanks again for watching, and until next time, keep asking questions and pushing for better solutions.